Good morning, everyone. We'll give it a couple more minutes for as people start to trickle in, um, and then we'll start. Today, as as a reminder, today is our this is our last grand rounds for the season. We saved the best for the last, so and then we'll start up again in September. So keep an eye out for the emails back in September. All right, so it's 8:01, so we can start. Again, good morning, everyone. It's my distinct pleasure and honor to introduce today's guest speaker, Dr. Zachary Smith, who is a professor of neurosurgery at the University of Oklahoma School of Medicine. He is the executive vice chairman of the department and the co-director of the neurosciences PhD program at OU as well. He additionally serves as the spine director at OUHSC. He's a graduate at Dartmouth for his bachelor's and then went to UCLA Medical School, and then he did his residency as well at UCLA. He did his fellowship training with complex spine at Northwestern. Currently, he directs a translational lab that studies markers of injury, neurophysiology, and neuromechanics of chronic spinal cord injury, including degenerative cervical myelopathy. Dr. Smith is a standing study section member with the NIH. He was previously funded by grants from the CNS, the Joint AANS CNS, and the European Spine Society. He also has a K23 NINDS from the NIH. He and his lab are currently supported through NINDS NIH with an R01. He has particular interest in markers of early injury and myelopathy. Today's talk has a little bit of something for everyone, from neurology, neurosurgery, emergency medicine, primary care, everybody. So again, it's my honor to introduce you today, and thank you for joining us. I know it's early where you are right now. Dr. Smith, you're still muted.
Can you hear me, Rudy?
Yes, I can hear you now.
Fantastic. Thank you for that great introduction. I'm really happy to speak to everyone. And I met Rudy a little bit more than a decade ago in Chicago before he started his residency. And he's a great doctor, has always been a great teammate, and really thank you for allowing me to speak today. So my talk today is going to be a research talk, but it's also a clinical talk, because I'm going to talk about a scenario that we see quite often, and that's cord compression in the cervical spine. These are the disclosures that I have. None are relevant to industry and just grant support for this research. And before I get going, I'm in Oklahoma City. Our program is based in Oklahoma City, and we have a hospital in the northern part of Oklahoma City. We have 7 spine surgeons, and we're starting a fellowship. We do have our first fellow named for next summer, and we're looking in the future. So we have MIS, robotics, endoscopic spine, deformity. We're a busy center. We're the tertiary center for the state of Oklahoma, and we draw from Tulsa and a number of other cities in the area. These are the pictures of some of my colleagues and a picture of our city. If you know of anyone who's interested, please reach out to us. We're getting going. We're not an established fellowship, but because I have the opportunity, in talks, I just want to let people know that we're doing this, and we think it's a great training opportunity. So if you know anyone interested in spine, feel free to reach out to me. So I mentioned this is a research talk, but around clinical scenarios that we see. We see these, and I'm glad this is a broad audience, because we see this in primary care, we see this in neurosurgery, we see this in the ER. We see this when we're learning neurologic diseases as well. This is a 70-year-old I saw last week. I brought this up because it was a recent case, and it's a patient that has moderate cervical stenosis. It depends on how you define it, but just very vague symptoms: neck stiffness, bothersome, tingling in the hands every once in a while. But a negative exam, no Hoffman's, no reflex changes, a normal tandem gait, really no issues there that would focus on the cervical spine. And he actually came for his lumbar spine. And you can see on the lumbar spine, there's a lot more going on, at least surgically. There's severe compression above autofusion, And if you see that X-ray, that shows there's quite severe instability. Now, one of the problems with spine is not that we have one option. We sometimes have 7 options for these patients. And the first choice is if we do surgery or not. So do we do surgery for this patient on the left image, the MRI that shows the cervical stenosis? Because we still have to do surgery on the lumbar spine. And again, there's like 7 different options for doing this. We could talk about this case all day, but we're trying to figure out more for the standards of the cervical spine compression. And I'm sure most everyone in the audience knows cervical myelopathy, so I'm not going to spend a great deal of time on this, but the very basics are there's a progressive narrowing of the canal. It's in patients as they get 45 and older. They have weakness in the hands. They often describe lack of coordination of the hands, difficulty with their balance. And as the canal narrows, you start to get both ventral compression and then dorsal compression. And then one of the things that's really important is that this is a stepwise decline. There's very little data and discussion about myelopathy with regard to conservative management and what we do about the mild patients. And that's going to be the focus of the talk today is what do we do with these patients who have mild disease? So one of the key things that's really become a major part of neuroscience in the last 10 to 20 years is biomarkers. And we know biomarkers quite well. So you see biomarkers all the time. Hemoglobin A1C is an example of a molecular biomarker. It's something that we use in all of our clinics, pre-surgical evaluations. But imaging biomarkers are something that are being more developed as we have new techniques and new technology. And these can really define what is normal and abnormal. And to have a really good biomarker, you want to actually have that. Define what is normal and abnormal, monitor disease progression, and then have response to treatment. So one example I give right here is looking at ALS. This is the imaging biomarker looking at gray matter loss. And with machine learning systems, this can be automated, and there can be something that you don't have to have what one of my colleagues calls adult watercoloring, where you go into the image, find the region of interest, and draw it out. And this will allow more standardization. And then it's very important to get repositories for sex-based, gender-based, and norms for levels. So multiple sclerosis is a great example in neurologic disease of biomarkers, both imaging and non-imaging biomarkers. So there's a paradox in multiple sclerosis where patients will have lesions, but it won't match up to their disability. So the need in multiple sclerosis was really look at markers for microstructural injury away from the lesion, so you can monitor disease as it progresses. And this focus has been on both brain and spine, and really looking at what's called a normal appearing white matter. So it looks normal in MRI, structural MRI that we look at, or clinical MRI we look at in clinic, but there are changes going on, and that's where you're going to see that progression over time. And I bring up MS because it is the example of a neurologic disease with advancement in the biomarkers, where we're at the primary endpoint now of clinical trials. So you can see it's gone from research and exploratory works, and I show 3 papers here. It's meeting all those goals for biomarkers. The one on the left, you see recent article, and there are many articles like this, track changes in tissue over time. And this uses markers for white matter injury. And then it'll track changes in normal tissue. And then recently, there have been at least 4 or 5 clinical trials that look specifically at neuroimaging biomarkers as the primary outcome in the clinical trial. So that's really kind of your endpoint of having a successful biomarker, is that you're using it for clinical trials and you're using it in your clinics and you're making decisions based on that. And one of the markers for MS is called magnetization transfer MRI. It's something that in my early experience with this research that we use to look at myelopathy patients. But imaging the spinal cord is very challenging. It's not as easy as imaging the brain, because the spinal cord, one, it moves. Second, it has lordosis, and that curvature, because it's not straight, makes it very hard to image. And then secondly, the CSF pulsations can have an impact. And then it's very hard to know exactly where in the spine, because of the size of the structure, the region of interest is. So we have developed, and our field has developed, techniques to address many of these things. One is segmentation. There is an open source software that I'll discuss more called the Spinal Cord Toolbox. You can actually get the region of interest, which is spinal cord, and then straighten it and segment the specific areas of the spinal cord. The partial volume averaging with the CSF does continue to create problems, but as we get images with MRI, we'll get smaller voxels and that will not get averaged in. And then as we developed regions of interest, as we improve our atlases, we can look at the areas of the spinal cord to find out what tracts and what part of anatomy is damaged. And a lot of this is open source and you can do it. Our lab does it. Many groups are doing it now. And we can look at areas that are injured in the spinal cord. And in 2018, when we had started this work for some time, this was our initial experience, like looking at biomarkers, however, we still had area to improve. And we looked at the specific biomarker called MTR. MTR is that marker that is used in pretty much all the MS studies. When you hear about biomarkers for cervical spine, it's normally MTR or DTI. And you can see these steps. We segment the cord, but then we have a cross-sectional area. This is segmented. And then we'll get a image of a normal cord in T2. And then there'll be a pulse of energy, and it'll actually take myelinated fibers to a higher level. When you get the difference between those two images, you can actually calculate a ratio. And in someone who has damage to the white matter, this ratio is changed. You can see in MS, this is a white matter disease, this can be impacted. In myelopathy, this is a disease likely partially and contributory wise to the white matter tracts. So we looked at the different regions of the white matter tracts that could be injured. So you can see at the bottom, this is a patient actually from Northwestern before I came to Oklahoma, looked at the different regions and could see the areas that were damaged. And you can see specifically where that asterisk is, compression in the spinal cord. And that anterior part of the cord was damaged. So our goal in doing this was to get patient-specific masks so we could have specific areas that were seen, get the specific level that was injured, and so we could associate this with their ongoing clinical evaluations. And it did grossly predict recovery, and that's one of the goals of biomarkers, to get prognosis. And you can see this is an area where that marker is decreased C3, C4, and C4, C5, where that injury is. The other thing is I circled the area where the compression is. On the very back of the cord, there's a blue signal, and that's demonstrative of the lower signal for this marker, but that may be some of that CSF pulsation. So there still is room to grow here in terms of our accuracy. Over time, we've refined this technique and we started to look more at regions of interest. We started to look specifically at automation of this. So if I did this here in Oklahoma and someone looked at my patients in San Francisco or Seattle, they'd get the exact same result. It's not based on you drawing out the regions of interest. And we found with that automation, we had much more refinement in our outcomes and the association with injury based on MGOA scores and clinical scores, and then also looking at specific regions of interest. Here, we've now found that the ventral spinal cord is the area where likely there's the most damage. And this is one of the next steps in getting this information, is looking at regions and tracts. And I just highlight Grace Haynes. This is one of our graduate students from the Norman campus, who's been the leader in much of this work. And she's going to hopefully graduate with her PhD this fall. So in myelopathy, there's a lot more information on biomarkers. This has been growing over time. There's multiple modalities. This is an example of 2 papers that have come out in the last 3 to 4 years. They are reaching those biomarker goals. Those goals include predicting severity, predicting outcome, prognostication. You can see this paper on the left. This is from Zach Ray's group at WashU, and this is looking at DTI. And they got DTI values on their patients before surgery and after surgery. They found that DTI markers predicted their response. And then you can see on the right, this is from a group in Montreal. The leader of this group is Julian Cohen-Haddad, who developed much of the technology for looking at the specific areas of the cord and looking at regions of interest. And they found that looking at the ventral columns, very similar to our MTR marker, was really the area that was most injured in the patient's myelopathy and may predict their outcomes. You can see here that FA, which is a DTI metric, is associated with the ventral column scores. So now we are getting to the point where we are getting to these biomarker goals, prognosis, associating with injury, and then hopefully we can get to the point where we can use it in our clinics. And this is a review that Ali Khan from our group wrote, and you can see that there are two key biomarkers that are being studied, DTI and MT. But also interesting is that a lot of papers, a lot of literature looks at multimodality, and that's likely also our future, that we're going to use multiple means to look at these patients. The other is that there's an explosion in the research that's been done in this field. You can see around 2014 to 2016, this research has taken off, but it's not just looking at one type of biomarker, it's looking at diagnostic biomarkers and predictive biomarkers. And then also over time, we'll be able to predict the response early after surgery and then the late response. So that data shows that we're making great strides, and we have a lot of publications on this topic. And we now have data to predict response, look at the area of the spinal cord. We have it in different modalities. We can automate it, but it's not translated to clinical care. If you go to a neurosurgery clinic today, or you talk to a neurosurgeon and you show them a picture of a patient with mild myelopathy, they're likely not using biomarkers. And I want to answer and discuss why is that, and how much there is a discrepancy from one opinion to the next. And I think that's where we're going to make a big difference. So despite all the accumulating data, here are some of the barriers that if you read something in JNS, if you read something in neurosurgery, what's going to stop us from getting to the point we're using it in clinic? So there are multiple MRI vendors. There are three major MRI vendors, Siemens, GE, Philips, and different centers have different MRI machines. Some centers actually have two different types of vendors, and that could create disparity between the outcomes. There is consistent variability in slice thickness used in different centers in different studies. So you may be looking at results from one center that would not apply to your center if you image them. The next is that we actually don't have a lot of healthy control data sets and very few disease state data sets. So we don't know what normal is for someone with spinal cord compression. And everything's not automated yet. Most of the research that you see being published is not based on automated regions of interest. A lot of these are still hand-drawn. And you can imagine if it's hand-drawn in one spot and hand-drawn in another, and you don't have consistency through that, your data is going to be impacted. And then a lot of the data is on 3 Tesla research grade scanners. And we don't image our patients in clinic on 3 Tesla scanners. Last, the focus is all on the spine. We may not know everything about cervical myelopathy. Is the brain involved? And is it also injured? Because patients who have injury to their spinal cord have less input to their brain. So I'm going to return to problems 1 and 5 at the end of the talk and mention why some of these actually are barriers that are fading, and we may get to that point. But I'm going to talk about the brain first. So we got very interested in the brain because of its potential impact on influencing how patients would respond to this compression. And I distinctly remember giving a talk at a conference, and one of the first questions was about this. He said, well, what about the supraspinal influences? What about the brain's involvement? Like, does this data mean anything if you don't know what's going on in the brain? And I kept thinking about that because we weren't looking at it. And there's early data and in other fields showing that the brain is impacted with fMRI. And also there's data in the literature for spinal cord injury. So in spinal cord injury, there's quite clear data on structural MRI and fMRI that if you have complete spinal cord injury, you have atrophy in the precentral gyrus, postcentral gyrus, and these are associated with ASIA scores. And then there's also animal models that show exactly that. So we hypothesize that the brain has the same influence that the spine has, but more in a modulatory mechanism. And this is also from Ollie, our postdoc. We have microstructural injury on the spine, but maybe we have cortical changes with atrophy and damage to the motor cortex because there's a lack of input. And then this may be why patients have a period where they have compression, but they can compensate, and they're quote unquote asymptomatic during that time, but they're really adapting. And I just wanted to read this quote. I think it's telling to us that 90% of stimulation and nutrition of the brain is generated by movement of the spine. So if you imagine someone who's Asia A, they lost all input to their brain from their extremities and their torso. They may not have the ability to keep their functional connectivity and their brain in the same state it was. And it's not surprising then that there are these changes. So we started looking at the brain. We started, all the patients would be going for spine research study, but we'd collect brain data. And we found what we found really interesting changes in the patients, that the precentral gyrus, postcentral gyrus would have quite significant atrophy over time. It was associated with the duration of symptoms. It was associated with the degree of myelopathy. And then also a lot of these areas that are associated with making movements, your prefrontal cortex, middle frontal gyrus, also your senses, your visual cortex, Heschel's gyrus, were also impacted, likely showing that there are areas that are compensatory or associated with the motor movements that we make on a day-to-day basis. And you can see some of these changes highlighted here on these maps. This is in 30 patients compared to age-matched controls. And the thickness, when it's a yellow or red, is actually showing a healthy control compared to the myelopathy patients, why it's increased there. So here on this table, you can just see precentral and postcentral gyrus. These are the heavy hitters in terms of changes, and they're significantly changed. If we had studied half as many patients, we would have had significance. Now, the interesting thing was it was not associated at all with their MGOA score. It was associated with motor testing, dexterity testing, and gait testing, and these may be more sensitive markers. And then we started following these patients and getting repeat MRIs on them. And one of the exciting things that we found was that the patients would get better. This was reversible. You can see the numbers are much smaller. We only have 9 surgical patients and 7 healthies that we followed a longitudinal analysis, and something we're continuing to study now. But we'd see these exact changes reverse after surgery, and these were 6 months after. And we've had patients longer after, and they continue to get closer to where a healthy control would be at that age. Probably not all the way back, but it's a reversible change. And these are 3 patients. Those are group level analysis. The last is kind of a culmination average of those patients, but these are 3 patients that we studied over time, and their balance and dexterity scores got worse if they did not have surgery, and their MGOA got worse after surgery, and they got better if they did have surgery. But you can see, patient on the left, 37-year-old, multi-level stenosis. One of my patients did a 2-level ACDF. The cortical thickness improved at 6 months. And then we had 2 patients who didn't get surgery, not because it wasn't offered or safe. 59-year-old 4-level stenosis, patient of my colleagues. He turned down surgery and then moved to Branson, Missouri. So we do all our MRI imaging in Tulsa. It's very close to Branson. Branson's about an hour and a half from Tulsa. In Midwest terms, that's close. But it's 2.5 hours from Oklahoma City. So we re-imaged this patient in 6 months, and they've just done another scan at a year and a half. And you can see that they actually have had continued atrophy over time. And then we've suggested very strongly that they get surgery. They don't want to do it, and it's their choice, but they've been happy to be part of the study. We see this atrophy is continuing. And then another patient who was very sick, had significant risk, was found to have a cardiac risk, about 20% for surgery. We followed them. They're doing PT, but they've had atrophy as well. So we can see that there's differences between patients who have surgery and don't. And this is beyond the scope of this talk, but we're starting to also look at their functional connectivity. We're seeing that connectivity patterns broaden over time in these patients. And there likely is connectivity changes that allows the brain to adapt. So you start using different parts of your brain to compensate for the injury that's going on. And then this may be why during the early period of this disease, patients don't have a lot of symptoms. So I think I tell our residents that the hardest part of spine surgery is not in the operating room, that it's in the clinic. And this is where we tend to make 90% of our errors. We obviously have technical challenges at times, but it's really hard to know who to operate and not in spine surgery. And that may just my personal opinion, but like it's something that I've realized this is where I make the errors. And I find this very challenging that we see patients who have compression in very different pictures. As I showed in that first case, there are different options, right? We could talk about, do they get laminoplasty, they get posterior cervical fusion, they get a front back, ACDF. But I think the first question is, do we operate on them in the first place? So 49-year-old with neck pain alone, tough. Do you do 4-level ACDF? Do you do a front back? Do you do nothing? Right now, I think probably most people would not do anything for neck pain. But this patient could have some ongoing compression that is leading to early injury. 42-year-old C6 radiculopathy, most people maybe do an ACDF here, 2-level ACDF, especially for the radiculopathy. And then 58-year-old with compression and multiple falls and neck stiffness, this is probably more into the will get surgery. Still many options, but these patients are not that dissimilar from each other, and maybe just a difference in time. And the disparity, the discrepancy between one surgeon to the next is quite tremendous. This is a paper I found very interesting. It looks at major societies and their surgeons doing a survey. CSRS and AO Spine were the two where they got most surgeons from. And they looked at mild myelopathy patients and they discussed this. And they asked these surgeons questions, say, what guides your treatment? And what's your follow-up time? And you can see it is a tremendous array of responses. So only 1% discussed advanced MRI. So obviously we're not there yet, and this is a recent paper. And then standard MRI, 42%. But you see CT scan, clinical severity assessment, flexion extension films, general health. It's just all these different things. We don't have set guidelines. Next, follow-up time. Some said 3 months, some said 6 months, some said 12 months. And then there's a small category said none of the above, when worse, depends on symptoms. So basically there's no set standard. And we still disagree on even what to call patients who have compression but not myelopathic symptoms. So we say cervical stenosis could be cervical stenosis without myelopathy, non-myelopathic cord compression, asymptomatic spinal cord compression, pre-symptomatic, just this large array. And with that, I just mentioned the variation. So we don't know what to call it. We don't know why we're operating. And then we also don't know when to follow up on these patients. So there is opportunity to improve here. But what we do know is that the myelopathy patients are often late to diagnosis. In my state, we have patients who come from the panhandle of Oklahoma in the southeast corner, and it takes about 3.5 hours to get here. And a lot of those patients, until they're really having problems with walking or their dexterity, they wait to come see a doctor. And they may be quite late into their symptomatic development. And the published findings show this, that the average response to time of diagnosis is almost 2 years. There is another paper that shows 46.4 months till time of diagnosis, and worse in rural locations in this paper. It is very similar to some of our experience. And then this graph in the middle, you can see 5 physician visits till the diagnosis is made. Then an important thing is it's the number one symptom of early myelopathy is neck pain. So patients may come in with neck pain, and that's what brings them in. And you can't look past that. So someone with neck pain may actually have early myelopathic symptoms. And it actually may be the reason they come to clinic in the first place, because when someone has pain, they'll be much more likely to come for evaluation. And then there may be a problem with diagnosis. So this was a paper that looked at UK records and found that the overall codes in the UK hospital system searching for myelopathy found about 0.2%. 0.19% precisely from this, and looked at the peak at 79 years. But then if you looked at meta-analysis from the Japanese literature, and likely our literature as well, it's about 2% of spines have asymptomatic spinal cord compression. So there's this large mismatch between what would be expected from cord compression and then what we're finding in the literature. Why this mismatch? So it could be misdiagnosis. It could be that there's not progression from having spinal cord compression found on MRI, and then it stops. Maybe there's autofusion. But it also could be it's overestimated. Last, it could be a prodrome. So we could be seeing patients who, like other diseases, are in a prodrome stage. And Rudy mentioned that this is a broad audience. There may be neurologists in the audience, and if you're in the audience and you're a neurologist, you know some of these prodromes. And if you're not a neurologist, you've heard of these prodromes, is that Alzheimer's disease now has a well-defined prodrome called mild cognitive impairment. There are CSF markers that can be found in these patients. If you do autopsies, they have atrophy in the medial temporal lobe. And that's something that progresses to Alzheimer's over time. Parkinson's has the same thing. Patients describe many years of daytime sleepiness, depression, urinary symptoms, and now there's actually a skin biopsy that can show that you're in this prodromic period of Parkinson's. And then I mentioned MS before, but it's one that we can learn a lot from, because they actually have a defined disease called radiological isolated syndrome, and that's a prodrome of MS. And patients will get plaques on their MRI and then also their spine, but they don't have a diagnosis yet, and they have these mild symptoms. And much of this is discussed because this could be an area for treatment. This could be an early opportunity for some of the medications that are being used for MS before they get into clinical disability of the disease. So where we are with our research now is trying to look at these mild patients and asymptomatic spinal cord compression, as well as continuing to look at the patients with more advanced disease. And we're trying to find ways to capture what is normal and abnormal to identify patients who have early compression. And our goal is actually to make it so that not just neurosurgeons, but doctors in the community can identify this and get patients to attention. And then hopefully with that, we can have trials where we have standardized set periods for reevaluating these patients and finding thresholds for intervention. So when you do see a patient with mild compression, you'll know exactly when you should pull the trigger on doing surgery. So one of the things that we're doing now is this morphometrics. This is the segmentation from the spinal cord toolbox that I showed earlier. And we're finding the area of maximal compression. We can get cross-sectional area in an automated fashion, AP diameter, transverse diameter, and then find that area where the spinal cord is compressed. This is a paper we published last year, really kind of getting this compression report card for patients. And this is now automated, and there's a code that you can run. And you can also translate research MRI to clinical MRI. So you could get this at any center. And you can see the specific areas of compression in patients with myelopathy on this on the left. This is 35 patients that we studied compared to healthy controls. And it does categorize patients just on morphometrics for mild and moderate disease. Used on any scanner, GE, Siemens, Philips, but you need to have the same slices that are used at each center. So this is example of this report card, but looking at these asymptomatic patients, quote unquote. I probably should have put that in quotes. Asymptomatic, it may be a misnomer, but these patients who have cord compression, but maybe these vague symptoms. So you look healthy controls, that's their cross-sectional area of the cord. We can also look at canal capacity in the same way. And then you could look at patients who have myelopathy, and that's in the red. But when you put these quote unquote asymptomatic patients in between, you can see this is likely a transition zone from going from healthy control to having myelopathy. And then if you follow them over time, on the left, you see baseline in 6 months. And then on the right, when we started following the patients again at 12 months, that inset shows that that peak compression is slowly getting worse. So if you have this potential report card for patients, and it may not be a neurosurgeon, maybe some in the community who can get this scan and see that there's compressions worsening, that may be a sign that this should be a patient that's referred for evaluation. So MGOA is not a perfect scale. I'm going to discuss that a little bit more because as we're improving on imaging, we also can improve on the clinical side in our evaluation. So you take those patients from that report card, healthy control, spinal cord compression, mild DCM. You see that those pictures left to right are very, very different. Open canal, compressed canal, severely compressed and distorted cord. But if you take the MGOA scale, they have the exact same scale. So right here, these patients in the circle, they all have the exact same MGOA score, 18. They have very different spinal cord AP diameters. They could be the same, but it's possible that our scale is what's failed. I think the MGA scale is not good. I think it needs to be improved. It does have a lot of value, and a lot of our data is based on it, but we could refine it and improve it. If you've seen the MGA scale, don't know it, I have it here. It has 4 questions. They're semi-subjective. It's non-granular. So you go from 0 to 4, but they're quite large jumps from each score. And you really only have 1 question on the upper extremity. And a lot of patients, that's what they complain of. Or someone will come in with balance and you have 1 question on motor dysfunction in the lower extremity, 1 question on sensory disturbance. So it may not be a good scale for diagnosis. And recent papers have shown that even with a score of 16, you can be 17 to have disease, but even 16 is only 90% specific. So one of the things that we started doing was doing specific deficit testing. There is something called the NIH Toolbox. It was designed actually at Northwestern. And then when I was at Northwestern, when I started, actually, I met Rudy. This was the place that I learned about the NIH Toolbox, is that there is testing that's developed in neurology to get dexterity testing, grip strength, balance, and gait speed. And it's easy to do. It takes 15 minutes. It does not impact your clinic flow. We have a separate room in the clinic. The patient will go get it done. We have multiple people who know how to do it. And then they come back to clinic. And if they're having surgery, we discuss surgery after they've done the testing. And then they can also do it the next day. They can do it at a different time and come back, but it's consistently 15 minutes. And we can get dexterity testing and grip strength. And then the balance testing really helps us as well. And it really kind of shows specific deficits in these patients, and it's not a 1 score outcome. And when you take those same patients that I showed 2 slides ago that had the exact same MGOA score despite the different canal diameters, they look different with dexterity testing and balance testing. Less so with grip strength, but there still are differences. But you can see on that top right graph that they have very significant changes in these specific deficits. So maybe what's happening is that our scale is not giving us good data. That's one of the reasons we think these patients are quote unquote asymptomatic. So I'm gonna wrap up the talk with discussion. Kind of we've gone through where we are and what we're looking at, and I want to talk about those last barriers. We discussed the barriers, and I've shown so far that there is strong evidence, and it's growing evidence for data imaging biomarkers of white matter injury. There are two markers. The publications have increased significantly. They're reproducible, and they're also anatomy specific. Brain structure likely is part of this, and we need to continue to look at brain structure and connectivity. And cord shape and canal reserve are quite important variables. And likely this is impacted very early, and there's early injury we may not be discussing clinically. Asymptomatic patients probably are symptomatic. I think that's a misnomer, asymptomatic cord compression. And hopefully, if there's anything you take away from this talk, when you see those patients in clinic, that they may be having earlier changes than we think. So I want to return to this question: why aren't we using these markers? So one of the barriers is that we don't have uniform MRI. And the solution to that is to have common methods. So 3 vendors, GE, Philips, Siemens, there are a couple others, but these are the primary 3 vendors, and different acquisition protocols at different centers creates a problem with the data. We can't look from one center to the next. So this has been partially addressed, and this is a study that came out in 2021. I was part of it, as were a couple of our collaborators on our work, and we submitted healthy controls to this database in the 42 centers, 260 patients, and they had all 3 devices, but it had set methods for where you centered the image, how you acquired it, the exact number of cuts, the field of view. This was set for DTI, MTR, those 2 markers, T1, T2, and other sequences. And this is available and it's open source. And all of our research now uses this exact protocol, and it's uniform. And if we are looking at another center's data, we will know if they're using the same protocol. And now the data that we're getting is actually on a different scanner. When I was at Northwestern and Siemens, now it's GE. And we've compared our results from our center to the previous data. We're getting consistent results even on a different scanner. So that may not be a problem moving forward. The next barrier is that a lot of the data, especially early from 2012 to 2018, was these hand-drawn analysis, this adult watercoloring. And then this is going to hopefully fade too. So we'll go to an automated analysis. Ken Weber and Julian Cohen-Adad. Ken is at Stanford, and Julian is in Montreal. They're really leading the way with a lot of this analysis and making it more automated and publishing their codes. And then we've looked at this for T2 signal change, and you can get an automated and quantitative amount of T2 signal change. And so even if it's faint, you can't see it, the computer will be able to tell you if it's present and to what degree. And we're doing that with our morphometrics. So that the data I showed, the morphometrics, we have it published online. This is a paper that's coming out. It's currently on GitHub, and this paper will come out with this code. You'll be able to use this code, or anyone will be able to use this code. And then the generic toolbox is also online. So hopefully this will be something that is open to the public, any center that wants to use it. And we have data sets that are open. There are more than 400 healthy controls on the open data set that's housed in Montreal and then open online. You can see here an example of some of the data that we had collected. This is from Northwestern that's used in that. But then also our myelopathy patients are online, and this open data set can lead to larger studies. Right now, it's mostly healthy controls, but as we get more myelopathy patients, that'll allow us to have disease-specific databases. So the solution to this is continuing to collect disease-focused data. A lot of other parts of spine are doing this, and lumbar spine's also doing this. MS, disease state, open databases are being opened. So hopefully this will improve over time and allow us to do larger studies. And then the last barrier I want to discuss was that The data is mostly published in 3 Tesla research grade MRI, but a lot of the data that I've shown can be translated to 1.5 Tesla. So most of our clinical scans are 1.5 Tesla. We can currently segment the spinal cord, get regions of interest of 1.5 Tesla. The only problem with that is you have to have a set protocol for imaging the spine that's used for every single patient. And we're doing that now, and we're hoping that we can get more centers to do that so that it's collected in the exact same field of view. And it's really easy. It's just you have to have the same field of view and the same gantry angle at every center. And I've reflected personally on like how far we've come. I was in clinic and I found this amazing that we have a light box there, and we never put films on it. And I put up films on the light box, and it's like once every 3-year occurrence now, because the patient came from out of state and they had the films, and we put it up, and everyone was surprised that we had a light box and they didn't know what it was. This probably shows my age, but like what my first 2 years in residency, that was like our number one goal when a trauma came in, was to get the films printed and put on the light box. But by the end of residency, we were completely on computers, and now like we almost never see this. So I think 2 or 3 OU residents now know what a light box is, but it's good that we're getting away from it, because you can imagine we never could do any of these biomarkers in this research if we had printed films, and analyzing it would be impossible. So we made significant progress in the last decade. We still have difficulty opening discs in MRI in every clinic in spine, but hopefully we'll get through that too and just get more standardized. And then we'll learn about these problems more and more and improve our clinical decision making. So these conclusions to the talk are pretty much the same ones that I showed, that we have growing evidence, they're reproducible, brain needs to be acknowledged. It's getting impacted early. Spinal cord shape and canal reserves impacted before myelopathy starts, and then asymptomatic patients are symptomatic. But with this last slides, I'm just going to add this to the conclusions, that our field has all the tools now to implement this. So you've been hearing about biomarker research for the cervical spine for probably like a decade, but we're at the point now that hopefully if you start seeing any use, you'll know why now, and you'll see why maybe we'll be imaging these patients in a different way and understanding them and having better ways to consider their early compression and timing of surgery. So just want to thank some of my collaborators. I put their names up here, and it's a picture of some members of my team. A lot of these papers that I showed were from postdocs and graduate students who've been working in my lab. And some of the researchers actually from Northwestern before I came here. I just want to thank Rudy again for inviting me. I'm happy to answer any questions.
Thank you for this amazing talk. It's a very thought-provoking, talk. It switches a little bit the gears for most people. Spine remains a biomechanical disease, not a biomarker disease. So I want to thank you for switching the conversation a little bit. Going from there, how has this, obviously you've been doing this research for 10, 15 years, you've been working on it. How has this changed your practice in when you see a patient in clinic with these diseases? And mostly, how has it changed the way you talk to these patients? Most specifically in those patients who have severe compression, like you mentioned, but very minimal symptoms outwardly, or grossly very minimal symptoms. Or the other side, those patients who have very minimal compression, you're like, I don't know, this is it, but also have like very myelopathic symptoms.
So really great question. I think if you're looking at these patients, you're studying them, and you're starting to learn that there may be injury that's early, it's hard not to change how you approach them. And I acknowledge I'm a lot more aggressive with myelocompression. I truly believe that they're having injury earlier. So a mild myelopathy patient for me is more likely to go to the operating room than before. I'm hoping that over time, like we can prove that they may need surgery earlier. I think on the flip side, I'm over a decade in practice now. It's like certain things I'm less aggressive about, and I didn't. It's a completely different can of worms, but like black disc, lower back pain, I probably operate on like 1/10 as many patients with mechanical lower back pain than I did, but I'm much more aggressive with myelopathy. So I do think, as I stated, it's really hard to make decisions in these patients because the guidelines for mild myelopathy show like incomplete evidence. And so we are doing this kind of guesswork, but I personally think we should be more aggressive with patients with mild myelopathy because the injury is starting earlier.
And there's as you mentioned before, when you see spine patients, it's not a lack of options. The abundance of options that make it more difficult. Do you do a ACDF? Do you do a posterior cervical? Do you do a corpectomy? Do you do a laminoplasty, laminectomy, fusion? Have you noticed any change or are you studying, is there any difference in the outcomes and the improvement of those biomarkers or in the improvement in clinical that corresponds to clinical improvement in patients depending on the approach, or is a decompression a decompression?
Um, I think that's where it gets a little bit muddy, right? Because when you do an ACDF versus a posterior cervical, you start to have different biomechanics for the outcomes, and the surgeries are so different, right? So someone who has an ACDF, they're going to have different complaints, right? They have maybe swallowing difficulty, but less pain. And then if you have posterior cervical, maybe they have a longer decompression, but they have more muscle pain. So I think that actually muddies the water in terms of figuring out how they're going to do neurologically. And I actually think that's one of the gaps in our spine literature, right? You mentioned at the beginning, we're looking at a lot of the biomechanics, but we're really not, we don't have great clinical scales for neurologic outcomes. We have a lot of semi-subjective scales. The other one I didn't show is the neuric scale with the EQ3D. We have like not the SF36, ODI, all these, they're semi-subjective. We don't have these quantitative markers to see the injury over time. So I think that's an area that we could improve greatly. And we also probably need randomized controlled trials in these patients to really see how they're doing. A lot of these are in terms of like having instrumented fusions and seeing how they're doing, like the sport trial. We may need some more conservative studies to look at the natural history of this disease.
Yeah. To your point as well, I think again, like the spine has been very focused on these biomechanics, but for our perspective, for the vascular world, for the cerebrovascular world, we have come to a point where we're now studying the cognitive outcome with neuropsych. That's why we have a neuropsychologist in our group, because it's somebody who has moya. It's not just about the strokes, it's about your slow cognitive decline over time. And I suspect that's happening as well, as you very well pointed out, in the spine patients who have these mild compression or even strong compression, but no symptoms, the quote unquote asymptomatic patients. So, there's one question I never know how to answer the patients in clinic for cervical myelopathy is, am I gonna get better?
Mm-hmm.
My go-to answer is like, we don't know. There is a percentage of patients who get better, a percentage of patients who don't get better, just stay the same, and a percentage who, no matter what we do, you're going to continue to get worse because there's already been enough damage that the process, whatever happened, is continuing to happen.
Mm-hmm.
Have you been able to clarify a little bit more which patient goes into which category?
Okay, so I think both my own clinical experience and the papers that published show that the patients who have symptoms that are about 6 months or less, and they have like a lot of edema on the cord, and they have had recent symptoms, even like last 3 or 4 weeks, they get a lot better. They get a lot better because they may not have progressed to that point where the cord is damaged via myelomalacia. I think the classic example is someone who's like in their 30s and they have an acute disc and they have a lot of compression. It's just recent change, and you operate on them and they have a phenomenal change. I think someone who's had 2 or 3 years of symptoms, hasn't been diagnosed, that they may not improve that much. I do think it's a real big challenge for what you said. Like, what do you tell these patients? It's quite hard because, you know, that they've been struggling with this over time. They're going to go through sometimes, especially if it's front and back, it's a really, you know, a lot of surgery for them, and they want to get better. I tell them honestly that the goal of the surgery, number one, is so they don't get worse. You're not, if we do the surgery, we're going to stop this progression that you're on. If we get something back, it's a bonus. I also warn them somewhat to what you asked you mentioned in the question, that if they do get something back, they're not going to get it all back, right? They may get a percentage back, but it's not going to be a complete relief.
Well, shifting gears a little bit, we have a question from one of our more seasoned surgeons, Dr. Stranger, who's dealt with this a long time. He said, how do you get around the guaranteed resistance by the insurance carriers to intervention on these mild myelopathy patients that don't meet their clinical criteria, their insurance clinical criteria?
Yeah, I mean, like I'm not operating on patients with quote unquote asymptomatic compression. I mean, like I still am operating on patients that have, you know, they have increased reflexes, they have long track signs. So I really have no problem with that. But I think in patients who are asymptomatic, and they have like neck pain and compression, I'm going to follow them a little more closely. And the second that they start developing myelopathy signs, then I'll do an operation. But I think that could be a challenge if we start finding that they're having a prodromal phase of injury. If we get to that point, then we're going to have a challenge with insurance companies.
Well, we're coming up to the end of the hour. Thank you very much for taking the time to you know, this is a fantastic body of work that you've, you know, presented to us today, and hopefully, you know, we can get specifically with all the open source data, you know, that brings in even more research and more advancement in our field. And I thank you for doing that, and you know, holding on to your own data. We can all benefit from that. And to everyone else, this is our last session of this season. Like I said, we ended on a high, and I appreciate you again, everybody, for joining us, and we'll be back in September. Dr. Smith, again, thank you so much for the
Thank
fantastic
you.
talk.
Great seeing you. I really appreciate it this morning.
Have a good day.